Welcome to episode 2 of DDQX Learning. I'm Dr. Brandon Deason, and in this video I'm going to show you how to correctly answer most questions on unstable angina. Let's start by taking a look at the case. Go ahead and pause if you want to give it a full read. I'm going to go ahead, get rid of the answer choices, and spread out the text a little bit. Alright, let's get started with the first P of my 5P approach, which is going to be to pause and identify the key information after each sentence. So, within the first sentence, we're going to want to keep an eye out for risk factors. So here we're told that the patient is a 59-year-old woman and that she has a past medical history of hypertension and type 2 diabetes mellitus. So it's worth noting that these are all cardiovascular risk factors. As we move to the second part of the first sentence, we're going to want to take a look at the presentation. So what's going on with this patient that's brought them to you today at the ED? So in the event of this woman, she started having this pressure-like chest discomfort and pouring sweat while she was just sitting there watching TV. So she was brought in by the paramedics who were able to relieve her chest pain after 20 minutes with the administration of sublingual nitroglycerin. They also gave her 325 milligrams of aspirin and started her on a 2-liter nasal cannula. Lastly, she has no chest pain now. Moving to our pertinent history, she has never experienced chest pain like this before. And she is taking medications lisinopril and metformin currently. Moving next to our initial findings, we have a mildly diaphoretic overweight woman. Her lungs are clear to auscultation bilaterally. Cardiac sounds, we've got regular rate and rhythm with no S3 or S4. Her 12-lead ECG is showing us T-wave inversions in leads V2 through V4. And those cardiac markers are within normal limits. And finally, for our additional info, our patient is started on heparin and metoprolol while awaiting cardiac angioplasty. Let's move on to that second P of my 5P approach, where we are going to paraphrase. Let's condense this information on down to just the key facts as you would report it back to the attending. So give this a quick read through if you want to get a feel for how that presentation goes. And let's use this to help us focus on our differential diagnosis. So, considering the presentation that we've seen of it being new chest pain, the length of its onset, our most likely diagnosis is going to be unstable angina here. Let's see how it compares to stable angina, NSTEMI, STEMI, and vasospastic angina. Our ECG findings here might be normal, or we might see ST depressions or T-wave inversions, reflecting ischemia, but not infarction, which is why our cardiac markers are normal. Stable angina is going to differ in the story predominantly. We're going to have that chest pain be something that they've experienced before, and it will come on with activity, be relieved by rest, last under those 15 minutes. Of course, with stable angina, we're only going to have a normal ECG, no ST depressions or T-wave inversions, and the cardiac markers are going to be normal. Comparing unstable angina to NSTEMI, it's important to think of these as a spectrum of the same disease process that's occurring. In both instances, we're dealing with a thromboembolic event where an embolism from somewhere else has broken off, moved to the heart, and come and clotted an already thrombosed vessel. So the difference here is that with unstable angina, it leads to ischemia of the surrounding tissue, whereas with NSTEMI, that chest pain stays more persistent. You see those same ECG changes because we're still dealing with less than 100% occlusion, so we're not going to see any ST elevations, but we do have infarction occurring with NSTEMI. So we're going to see Cardiac biomarkers being elevated. Remember that it is subendothelial infarction that's occurring with NSTEMI. Moving to STEMI, we're going to have that sudden persistent chest pain, the ST elevations that are the hallmark of its name, and the cardiac biomarkers being elevated from the transmural infarction that's occurring there. Lastly, vasospastic angina would come on at rest. Typically, status post-substance use is what you'll see in question stems. We're also going to remember this is a diagnosis of exclusion, so everything else is going to have to be ruled out first. The ECG is going to be normal in that case, so the presence of the T waves and inversions here is stroke against this diagnosis, and we would expect cardiac markers to be normal. Moving on to our third P, it's time to apply what we know and predict the language of our correct answer choice. So, what do we expect in terms of vessel occlusion given the symptoms that we have with our patient? Well, greater than 70% is expected anytime we have a patient with chest pain like this. In terms of how ST segment changes are affecting, we expect less than 100% occlusion if we don't see ST elevations. Looking at how the leads correspond with the anatomy involved, we are expecting an anterior chest wall issue anytime we have V2 through V4 problems. And how do we expect these changes to match up with the vessel? Well, the left anterior descending is going to be the artery that feeds the anterior portion of the left ventricle, so that's where we're expecting our occlusion. Moving right along to P number 4, it is time for us to compare that prediction and pick an answer choice. Again, do not let the work of a prediction go to waste, so let's pop that up on the screen and take a peek at how that relates to these answer choices. If you matched answer choice D, you are correct. Bringing it home, P number 5, preparing for future cases. So I've generified this question stem for you. Take a look through, write another case that you would expect to see down the road, and I look forward to seeing you in future videos. You might be thinking, Dr. Deason, you look like a nice enough guy. But why should I care what you're saying? Well, I have never been a clinician, so let's just get that one out of the way. But good news is you don't need somebody with clinical experience to tell you how to pass an exam. I am a standardized test expert by trade. I have analyzed and researched underlying patterns of the major standardized tests that are out there. I have developed workflows for how other writers can then make test-like content that is similar to that exam. And that is where I made my career. Now I am coming and bringing my methods straight to the student and showing you how to think like a test writer, break it down from how this story is being presented, follow the clues, and see how it's all adding up to one diagnosis, as well as giving you cons on the other items on that differential. So I hope that you keep following me and see how this method is applied to a number of different scenarios over this year, and thanks for watching.